Good morning, and welcome to the October meeting of the New England Comparative Effectiveness Public Advisory Council. The subject of today's meeting is Valrox and Emicizumab for Hemophilia A without inhibitors, effectiveness and value. We are going to ask that all members of the New England CEPAC introduce themselves shortly. But one thing that we do at the beginning of every New England CEPAC meeting is ensure that all speakers disclose any financial relationships with industry. Every member of our New England CEPAC panel today has met the ICER conflict of interest policy. As I call on you individually to introduce yourself, would you just please update any conflicts of interest that may have arisen since this declaration? And so I'll begin with myself. My name is Rob Azeltine. I'm professor and chair of the Division of Behavioral Sciences and Community Health and director of the Center for Population Health at the UConn Health Center. I'll now ask Rena Conti to introduce herself.
Rena Conti, I'm a health economist at the Questrom School of Business, Boston University, and the Associate Director of Pharmaceutical Policy at the Institute for Health System Change. I have no updates to my conflict of interest.
Thank you. Megan Golden.
Hi, I'm Megan Golden. I'm co-founder and co-director of Mission Cure, a nonprofit patient advocacy organization, and I have no updates to my conflict of interest.
Thank you. Claudia Gruss.
I'm Claudia Gruss. I'm a gastroenterologist and clinical educator with New Vance Health System in Southwestern Connecticut. I have no change in my conflicts of interest.
Thank you. Claudio Gualtieri.
Hi, Rob, and good morning, everyone. I'm Claudio Gualtieri, Senior Advisor at the AARP Public Policy Institute. I work with a network of state action coalitions and AARP state offices to improve patient access to care, support family caregivers, and build health equity. And I have no new updates to my conflict of interest.
Thank you, Claudio. Rebecca Kirch.
Good morning. I'm Rebecca Kirch with the National Patient Advocate Foundation. I'm based in Washington, D.C. And I have no updates to my conflicts.
Thank you. Steve Kogut.
Good morning. I'm Steve Kogut. I'm a professor at the College of Pharmacy at the University of Rhode Island, where I direct our graduate program in health outcomes research. I'm also a member of the Rhode Island Drug Utilization Review Board, and I have no updates to my conflicts of interest to report.
Thank you. Tara Lavelle.
Hi, everyone. I'm Tara Lavelle. I'm an assistant professor at Center for Evaluation of Value and Risk in Health at Tufts Medical Center in Boston, and I have no updates to my conflict of interest.
Thanks. Kim Lenz.
Good morning, everyone. Kim Lenz. I'm the clinical pharmacy manager for the Massachusetts Medicaid program. I'm also assistant professor in family medicine and community health at the University of Massachusetts Medical School. I have no updates to my conflict of interest.
Greg Lowe.
Good morning. I'm a pharmacist and pharmacoepidemiologist and the director of the Mass General Physician Organization Quality and Utilization Pharmacy Program.
Thank you. Eleftherios Mylanakis.
Good morning. I'm a clinician and researcher. I am a professor of medicine at Brown and direct the infectious diseases divisions at the Brown hospitals.
Stephanie Nichols.
Good morning, everyone. My name is Stephanie Nichols. I'm an associate professor at the UNE School of Pharmacy, and I also see patients in the areas of psychiatry and substance use disorder at Maine Medical Center. And I have no updates to my conflict of interest.
Thank you. Leslie Ox.
Hi, everyone. My name is Leslie Oaks. I'm an associate professor at the University of New England School of Pharmacy. I'm also chair of the Department of Pharmaceutical Sciences and Administration, and I have no updates to my conflicts of interest.
Thank you. Jean Ryer. Jean might be on mute and is having internet connectivity issues, so we might come back to her.
Can you hear me now?
We can hear you now. Thanks, Jean.
All right, sorry about that. I'm Jean Ryer. I direct the New Hampshire Citizens Health Initiative, and I lead work on delivery system and payment reform at the Institute for Health Policy and Practice at the University of New Hampshire. I have no updates to my financial conflict of interest. I do have extended family members with hemophilia, and so I consider that an enhancement to understanding and not a conflict.
Thank you. Jason Schwartz.
Good morning, I'm Jason Schwartz. I'm an assistant professor at the Yale School of Public Health in the Department of Health Policy and Management, and I have no updates to my conflicts of interest.
Thank you. And Jason Wasfy.
Good morning, I'm Jason Wasfy. I'm a vice chair of New England CEPAC. I'm a cardiologist and Mass General assistant professor at Harvard Medical School. I direct our program in outcomes research at the Mass General Hospital Heart Center, and I'm a medical director of our physicians organization. Good to see you all and hope you're staying safe. I have no updates to conflicts.
Thank you, Jason. And that is our CEPAC panel. And I will note as well that I do not have any updates to my conflict of interest. So now I'm going to call on the patient and clinical experts that we have with us today to introduce themselves and again, declare any potential conflicts of interest. Mark Skinner.
Good morning. It's nice to be back with you again a couple of years later. I run a research organization focused on patient outcomes research in the hemophilia community. I'm previously president of the World Federation of Hemophilia and the National Foundation, and serve as an assistant professor on the faculty at McMaster University. I have no additional conflicts to report other than the research-related funding previously disclosed.
Thank you. Brian O'Mahony.
Good morning. My name is Brian O'Mahony. I'm Chief Executive of the Irish Hemophilia Society, and I also have severe hemophilia B, which means I hope I can be objective about hemophilia A. I don't have any additional conflicts apart from those I've already reported. Thank you.
Thank you. Dr. Margaret Ragney.
Good morning. I am a professor of medicine and clinical and translational science at the University of Pittsburgh and medical director of the Hemophilia Center of Western Pennsylvania. I have no update to my conflicts of interest.
Thank you. And has Dr. Stephen Pipe been able to join us?
Yes, good morning, everyone. Looking forward to today's presentations and discussion. I'm a professor of pediatrics and pathology at the University of Michigan. I'm pediatric medical director for the hemophilia program here and also direct the special coagulation laboratory. And I have no additional conflicts of interest other than what we've already disclosed.
Thank you very much. And so before I turn this over to Dr. Stephen Pearson, I'll just note that we are going to request that any other speakers or any of our policy roundtable participants or anyone making public comments, if they would please disclose any potential conflicts of interest that they have with industry so that others may judge any potential conflicts as they are presenting their position. We will also present this information publicly on our slides. And now I'll introduce you to Dr. Stephen Pearson.
Thank you, Rob. Good morning, everybody. Yes, I get the benefit of using slides. So, and as you can see, for those of you who aren't in New England, winter has come early here, so that you can see a kind of a whiteout behind me. It's actually quite beautiful, but it does remind me, snow in October 2020, we can probably expect locusts, frogs, whatever else is coming our way. But I hope you're well and that you and your family are navigating as best as possible during these difficult times. So the next slide, please. Why are we here today? We like to start off to make sure that we set a context before I hand it over to others. And here's a quote from a person with hemophilia. As a person with severe hemophilia who has survived to celebrate my 76th birthday on October 10th, 2020, I can reflect on the advances in treatment over the past 7 decades. I have confidence that my great-grandchildren, if they have hemophilia, will benefit from miraculous treatment advances and perhaps even a cure. Next slide. So why we are here today, advance please, is to recognize what happens the day that these kinds of treatments, among which we'll be talking about a couple today, what happens when they're approved by the FDA? And part of what happens is a celebration. There's a feeling of years and years of hard work, of risk-taking, of engagement by patients and patient community experts in their clinical trials, by clinical researchers who often take risks and head off in new directions, and by companies that invest in the science behind these, as well as our federal government that does the same. So there's this amazing engine of innovation that is celebrated the day that these treatments are approved. Now, the other thing that happens that day, not always that single day, but right around that time, is that decisions, very important decisions, are made that affect access and affordability. And these include decisions around the price that will be charged. It includes decisions around where things go in the formulary, or whether there are treatments that have to be tried first before you can get access to this. And all of this happens pretty quickly around the time of FDA approval. So that's partly why we're here today, is to wrestle with how we can help inform those decisions, not just for perhaps these treatments today, but also as a platform for thinking about it more broadly. Advance, please. So part of the perspective that I think is the goal of today is to think not only about the patients that will be receiving these treatments, but also others in our loosely called healthcare system. Next slide. And to bring that perhaps into a bit of a personal aspect, because it's often hard to think about the patients who aren't in the room in front of us if we're clinicians, or the people who are in the health system whose lives are affected by what we do every single time we make decisions around pricing and access. So what we face in America, at least, is a constant tension with the issue of innovation and the cost of our system, and when there isn't enough money in the overall system to help us support health insurance for everybody. So these are three people, and today, partly because of Medicaid and the expansion of the Affordable Care Act, these are people who usually slip through the cracks because they don't qualify for subsidies, or for other reasons. The health insurance is still unaffordable for them. And these folks were covered in a news article. Gustavo Bendek is a physician's assistant in Texas, and he and his wife felt that they just could not afford the rising premiums that they were encountering, and they had to go bare without health insurance. And in the report, it talks about how uncomfortable and anxious that leaves them as a family. The Whitmans have a family with children, and there for more than 4 years, they have felt that they could not afford their health insurance. And during that time, both children have had serious injuries and were not taken to the emergency room. And the parents were quoted as saying that they really worry that they're doing long-term damage to their kids sometimes by some of the decisions that they have to make because they can't afford the health insurance or the cost if they were to go to the ER. And Luke Breen is actually a small employer who wants to provide insurance for his relatively small staff, but has not been able to afford it for them and has seen them suffer the consequences. He's lost employees just because they had to go find insurance elsewhere, but even the ones who stick with him, he sees the struggles that they go through. So this is part of the larger lens, if you will, the larger framework within which we meet to talk about the evidence and the value of new treatments. Next slide. And if I could make it very, very schematic, the issue is that we want to always keep foremost the patient and their family in front of us, the people who will benefit from treatments that we're talking about today. But if you continue to advance, the idea is that we have to do this in a way that creates a system that can keep all of us together, covered, and able to access high quality care at an affordable price. And it's the ability not to think of this as some kind of competition where some groups win and some groups lose. We all want to be part of a system that can do both. And if you hit the advanced slide, this is just captured by this idea that this is the system we want to be patients in. This is the one that we want our family to be in, and we want to create this going forward. Next slide. So you've been introduced to the members of the New England Comparative Effectiveness Public Advisory Council, or CEPAC. They're an independent group that we convene to wrestle with these issues around evidence and the bigger system. I need to tell you a little bit more about ICER, which is the convening host and, if you will, the academic secretariat for this event. Next slide. So on our website, we keep an updated picture of our funding sources for 2020. As you can see, this includes the largest chunk from nonprofit foundations. And that among those groups, the largest is the Laura and John Arnold Foundation, the California Healthcare Foundation. We also receive funding from, have received funding recently from the Commonwealth Foundation, the National Institute for Healthcare Management Foundation. That is the money that we use for our research and for these meetings. We also receive direct support from health plans and provider groups and life science companies, manufacturers, that sums to just short of 30%. We use that exclusively to support a policy summit and other non-report activities. And so the nonprofit foundation support is what we use for the science and the meetings that we hold. Next slide. So the report itself, that's the backbone of this of the discussion today, comes from a process that extends over 8 months in time. And it starts with scoping, what we call scoping, which is a time when we try to sit back and say, teach us what we don't know about the experience of living with this condition. We start with patient groups, we talk to clinical experts, certainly talk to the manufacturers and other stakeholders to try to get a grip on the multiple dimensions of the patient experience, the diversity in that, the sources of evidence that we might not be aware of, and the broader view of what value means to the patients and families most directly affected. Then we go off and we do a staff project of evidence analysis in which we look for all the evidence, we generate new evidence if we can, that can be complementary to what can be found publicly. And we work with the manufacturers and sometimes can receive confidential information. All of that information is looked at and analyzed, and we also work with outside academic health economists quite frequently. In this case, it was experts at the University of Illinois, Chicago, who lead the effort on the cost effectiveness modeling. All of this goes through different iterations of back and forths with public comment, including direct communication with patient groups and the manufacturers, several rounds of revision. And we also have the benefit towards the end of expert reviewers, including the two clinical experts who will be with us today, Dr. Pipe and Dr. Ragney, and also the patient expert in this case is Mark Skinner, and you will get to hear more from them as we go forward. So a brief discussion now about how the evidence in the report is structured in a way to help us in what we think is the conversation around value that will help us get to that system that I talked about earlier. Next slide. So we start again conceptually with the idea that we want the evidence report structured to support decision-making that will achieve the triple goal of fair pricing, fair access, and a system that can guarantee future innovation. To do that, we believe that decision makers need evidence conceptually in two major buckets, advance. One we call long-term value for money, and the other is a short-term view on budget impact or affordability. Now, the members of the New England CEPAC will be familiar with the different buckets that I usually show in a further animation on this slide. I'm going to do it slightly differently today. If you advance to the next slide, I'm going to talk about long-term value for money, and you're not going to know how I'm going to get there yet, but hold tight. I was able to go on a trip to Japan a few years ago. I did not take this picture, but one of the things that visitors to Japan will note is obviously the Japanese pagodas that are so well constructed that they last centuries. And this is one in front of Mount Fuji. If you hit the next slide and continue to accelerate through the three pictures. What's interesting is that there are different styles of pagodas, but there's a common one that has 5 floors. And these are from an ancient Buddhist kind of tradition in which the universe was comprised of 5 elements: earth, water, fire, air, and spirit. And the goal here is for these to be supportive of each other and in harmony. And that's one of the reasons these buildings last so long, is because they're built with that in mind. And so I'm going to use this kind of general concept of 5 different elements in harmony to try to describe how we think about long-term value for money. Next slide. So if you take this as the prototype and you kind of click through, imagine each floor is representing a piece of long-term value for money. Because first, what we do in the report is we look for health benefits. And a treatment could improve our health by giving us a longer life. And or it could improve our function, take us from where we are today and make us better. It could also provide benefits by having fewer side effects than another treatment that we might otherwise need to take. All of these are important parts, but we also have to think again, if it's long-term value for money, about the total cost, not just the cost of the treatment that we're thinking of here and now, but the cost that it has throughout the system. And that could include cost savings if it helps reduce the need for other treatments or visits to the doctor or hospital. And last but not least, we have to always remember that in a broader view of long-term value for money, there are benefits beyond health and considerations around special social or ethical priorities. So in our report, if you hit the next button, you'll see that for the first 4 of these, and you hit one more, apologies for all the animations, but this can kind of be summed up in a question about how much extra should we pay for the better health that we get. And that's the classic question that cost effectiveness asks. But then if you hit the advance, we also have to think, what do we do with this other element, if you will, this benefits beyond health and the special social or ethical priorities, some of the broader aspects of value that are important too. So the next slide shows how we kind of put cost effectiveness into this as a part of how we think about pricing to the value. Now, the bottom row there shows the way that a cost effectiveness analysis, and this is in the report, can say at what price would we get a certain threshold of kind of paying how much we would want to pay for added health when summed up across longer life, improvements to function, and fewer side effects. And recent research is showing that if you hit the next button, that there's a sweet spot, and that this represents the maximum price at which we can reward the innovation and the benefits that we can realize for those patients right in front of us that we're going to use this treatment on, and keep that circle whole, that we can pay for added health at a higher cost within a reasonable proportion and keep that. And there's good research that'll actually be forthcoming shortly in Annals of Internal Medicine to justify a number that's been out there for a while, that it's around $100,000. So remember that question of what we do with the benefits beyond health and the special priorities. So if we're thinking about $100,000 as the kind of top price we could pay to keep that sweet spot, if you click again, you could imagine that we could start with a range of pricing between $50,000 per quality or equal value of a life year gained and $100,000, and then click again. That's when we would, within that range, we would consider the benefits beyond health and the special priorities to help us figure out where we should be. We have chosen, for a variety of reasons, not to go from 50 to 100, but if you click again, we go from 100 to 150 in our own reports. This is for multiple reasons, but it means that some people will think that 100,000 should be the top threshold price at which we would have good value in our healthcare system. We tend to discuss it at a range higher than that, partly because there's continuing interest in trying to understand how we really do think tangibly about these benefits beyond health and special priorities in the American healthcare system. So that is where we are today with the report, and that is kind of the underpinnings for the discussions we'll have today to some extent. If you hit for the next slide, the idea again is to think of how we can structure our view of evidence, our translation of it through into how we do pricing, how we do coverage, how we do patient education, clinician education, and make it all work as a system that can accomplish what we really want for ourselves and our families now and in the future. So with that, the agenda for today formally, if you click again, is the following. I'm not going to run through all of this, but it will start with a discussion of the clinical evidence, then move to the economic model information. We'll have public comments and discussion, including comments from the manufacturers. After a short lunch break, we will come back to have further discussion and voting on issues of clinical effectiveness and broader aspects of value. And then the day will conclude with a policy roundtable where we will have patients and patient experts, clinical experts, payers, and manufacturers around a roundtable to think about how we move forward to translate this evidence again into policy, into practice, and into a future healthcare system that we all want to have. So with that, let me then hand it over to start this discussion. Oh, I'm sorry. This is kind of a formality because they've already had this discussion as part of their introduction. But in the small print here, you will find the disclosed conflicts, financial and otherwise, for our clinical and patient experts who will join us throughout the day and are available to the CEPAC at any time to give context and to provide their perspectives. Brian Mahoney, Mark Skinner, Stephen Pipe, and Margaret Ragney. So thank you to them again for being with us today. I'm not going to read this. It's available to you. And let's get right into it. So with the next slide, I will hand it over to Dr. David Rind, ICER's Chief Medical Officer, who will introduce us to our analysis of the clinical effectiveness review. David?
Thank you, Steve. I'm watching to see whether the picture changes to me or not. Can we go to the next slide? Key collaborators on this are listed, and we have no conflicts of interest relevant to the report. I do want to mention that the hemophilia community, including the experts you just heard about, the patients, the clinicians, have just been amazing, as they were with our last report, about providing information ranging from clinical information to patient-reported outcomes to economic help. And it's like nothing else really that ICER experiences in our other reviews. Next slide. So hemophilia A, it's a deficiency in factor VIII with an increased tendency to bleed. It's an X-linked recessive disorder affecting about 1 in 5,000 male births. There's a risk for life-threatening bleeding, such as into the brain, but more commonly, we're talking about bleeds into joints and muscles that hurt. And joint bleeds can lead to further bleeding into those same joints and progressive joint damage, and eventually arthritis and often joint replacement surgery. Next slide. Factor VIII for home treatment of bleeds became available in the 1970s. And then by the early to mid 2000s, factor VIII infusions for prophylaxis became routine in severe hemophilia A. And a little bit after that, actually, is when randomized trials demonstrated the efficacy of this prophylaxis. Next slide. Prophylaxis with factor VIII is burdensome. The factors are administered intravenously. They have to be given 2-3 times a week, sometimes more. Venous access can be difficult in young children. Very young children may require a report for access. Elderly patients and those who develop arthropathy may find self-administration difficult. And as a result of all of these things, adherence is a substantial problem. 50 to 70% of patients adhere, but that means 50 to 30% don't. Next slide. We have a chart in the report looking at the interaction between patient and caregiver restrictions and aspects of hemophilia that was sufficiently confusing that my group told me I had to do this as a bulleted list. I'm going to point to just 2 of these things. If you look at the upper right and look at caregiver career, if you're taking care of a child who needs infusions multiple times a week and who may require care anytime they bleed, you need a job that has flexible time. If we look over at patient career on the left, you need to be near specialized care and have accessibility of factor. You're not going to go take a job working on an oil rig in the ocean. It's just not possible. And there are many restrictions of this sort. Next slide. So we're first going to talk about Valoctocogene Roxaparvovec, which I'll call Valrox for the rest of this presentation. It is an adeno-associated virus liver-directed gene therapy. It's done as a one-time administration to adults or to late adolescents. In August 2020, the FDA issued a complete response letter not approving Valrox for the time being. Next slide. We're also then going to be talking about Emicizumab, which is a bispecific antibody that bridges activated factor IX and factor X, which is the role normally played by activated factor VIII in the clotting cascade. It's a subcutaneous injection that's given every 1 to 4 weeks. It can only be used for prophylaxis. If you bleed while you have Emicizumab around, you can't give more Emicizumab to deal with that bleeding. It was approved for patients with inhibitors to factor VIII in 2017, and that was the focus of the prior ICER review. And it was approved for patients without inhibitors in 2018. Next slide. So our review today in this report is people with hemophilia A without inhibitors to factor VIII who would be appropriate for routine prophylaxis. And for Valrox, again, we're talking about limiting that to adults. The interventions are gene therapy with Valrox and prophylaxis with Emicizumab. The comparators are each other, but also mainly to prophylaxis with factor VIII, but that we had to assess in different ways because of limitations in the evidence. For Valrox, we're looking mainly at achieved factor levels with the gene therapy. Factor levels are a surrogate outcome. They're not inherently patient important, but they're an extremely good surrogate that predicts patient outcomes very well and may be better than a number of other outcomes. Emicizumab was assessed mainly by looking at annualized bleed rates, which is a patient important outcome. We're looking at how often people bleed, but there are problems with it. Next slide. We heard specifically from patients and patient groups that annualized bleed rates don't adequately capture all aspects of the benefits, burdens, and harms of prophylaxis. Among other things, as has become perhaps more recognized because of Emicizumab, there's a sense that patients are having microbleeds that they wouldn't previously have recognized necessarily as bleeds, but which cause pain, and which, if aren't happening, pain reduces over time. We also heard about the ways that a curative therapy with gene therapy could be transformational in ways that even someone with hemophilia may not be able to understand before it happens. We talked to a patient who had gotten a liver transplant about how he just no longer thinks about himself as having a bleeding disorder and just doesn't have to worry about it at all in his day-to-day life. We also heard about how patients and patient groups have struggled to get insurance coverage for dosing regimens that maintain higher trough levels of factor VIII. Between injections of factor VIII, as soon as you infuse factor VIII, the levels start going down over time and at the lowest point right before you infuse again. And we'll come back to this issue when we talk about dosing. Next slide. Next slide. So to understand Valrox, we have to talk about how severity of hemophilia is classed. And severe hemophilia is usually considered to have a factor VIII level less than 1% of normal, moderate from 1% to 5% of normal, and mild higher than 5% up to about 40% of normal. Above that, people are generally not considered to have hemophilia, certainly not above 50%. Those classifications aren't perfect. Not everybody who is in one of those buckets really has the phenotype of that, but on average, those are good buckets and they're typically used in the literature. We looked mainly at a phase 1/2 open label dose finding trial in 15 patients. The primary endpoint was factor VIII activity above 5 international units per deciliter, which would put them into the mild range. And that was achieved by 4 out of 5 patients who received 4 × 10⁻³ vector genomes per kilogram, and by all 7 patients who got 6 × 10⁻³. There were a few other patients who got lower dosing. Next slide, or animation. We're going to focus on that 6 × 10⁻³ because that's what people are imagining actually administering. Next slide. This shows using 2 different assays, and I have both the assays here really just because this may come up in further conversations, both in the report and in the policy roundtable. But you can see that starting in year 1, on average, people are in the non-hemophilic range, and it declines substantially year after year after year. If we look at that next slide, in this more conservative chromogenic assay, we see that 1 patient was still in the non-hemophilic range at year 4. 4 were in the mild range, 1 in the moderate range, and 1 was back in the severe hemophilia range. Next slide. Using the 1-stage assay, you see 2 in the non-hemophilic range and 5 in the mild range. So this is an assay that tends to have higher levels than the chromogenic. Next slide. Some other results and information about Valrox. The mean ABR dropped from 16.3 bleeds to 0.8 bleeds after 4 years. In years 2 through 4, 6 out of 7 patients had 0 bleeds, whereas only 1 of 7 patients had that at baseline. Quality of life measures increased each year after receiving gene therapy. The most common adverse event was an increase in liver enzymes. That's often seen with AAV therapies and was treated with steroids in some patients. And all patients developed antibodies to AAV5. There is a phase 3 trial underway. We have very limited data from it, but on results in 16 patients, only 7 of them achieved the primary outcome of getting above 40 IU per deciliter, that is into the non-hemophilic range. And that looks worse than, or it looks like it's probably worse than what was seen in the phase 1/2 trial for uncertain reasons. Next slide. Emicizumab, switching gears. We have the HAVEN3 trial. HAVEN3 is an open label phase 3 randomized trial in patients without inhibitors. 89 patients not receiving prophylaxis were randomized to 2 dosing schedules of emicizumab versus no prophylaxis. There were an additional 63 patients who had been receiving prophylaxis who were analyzed in a before-after study being switched to emicizumab. We compared that with a randomized trial of factor VIII that was very similar, SpinArt. It was an open label RCT of factor VIII versus no prophylaxis in 84 patients. It used standard half-life factor VIII. There were both standard and extended half-life preparations, and it was dosed at 25 international units per kilogram 3 times weekly. That's a lower dose than is commonly being used in the US today, and we'll come back to that. Next slide. So here's a network meta-analysis comparing emicizumab to that dose of factor VIII. This is comparing HAVEN3 and SpinArt. And you can see in the red circle that emicizumab, red square, that emicizumab substantially decreased annualized treated bleeds and annualized treated joint bleeds, although as is typical in an NMA of this sort, it had quite wide confidence intervals around that. You can also see in that bottom row how both therapies are dramatically better than just giving on-demand factor VIII. Next slide. Other information and results on emicizumab. We had real-world evidence that we looked at on bleeds in 39 children who switched from factor VIII to emicizumab. Their annualized bleeding rate decreased to 0.2 from 1.1 when they'd been on factor VIII. And the percentage of children who had 0 bleeds in 6 months increased to 94% from 73% on factor VIII. In HAVEN3, there were not statistically, but non-statistically significant improvements in quality of life versus no prophylaxis. That is, the point estimates for quality of life were higher, but this was not statistically significant. There were fewer missed days of work versus no prophylaxis. And in the before-after portion of HAVEN3, 98% of patients preferred emicizumab to factor VIII prophylaxis. And in fact, in another HAVEN study, 100% preferred emicizumab to factor prophylaxis. The most common harms with emicizumab were injection site reactions. Next slide. In terms of uncertainties and controversies with Valrox, very few patients were studied and reported on. The interim phase 3 data that I mentioned appear to show lower success rates, and that's concerning. Factor levels are clearly declining over time. They start high and quickly come down. The target cell for the gene therapy is hepatocytes, whereas factor VIII is normally made in the liver, but it's made in sinusoidal endothelial cells. And it's possible that that both increases the risk for decline, and there are some concerns about whether that could cause liver toxicity over time. Next slide. For emicizumab, in terms of uncertainties and controversies, the effect on inhibitor development, particularly if starting with emicizumab in infants, is unknown, but there's very likely to be one, and there's a lot of thought that it might decrease inhibitor development or delay inhibitor development, and that's very important. The best randomized trial evidence is against doses of factor VIII lower than are typically used in the United States today, substantially lower. And so while we have an NMA against that lower dose, we don't have an equivalent study of the higher doses used today to give you estimates of the sort we did. Randomized trial evidence may overestimate adherence to a burdensome therapy. In randomized trials, people are pushed to adhere and they're very good about it. So when we're talking about factor VIII and how it did in a randomized trial like SpinArt, it's quite possible it did better than it would do when being used in the real world. Emicizumab is much less burdensome, and so adherence is likely to be more similar to a randomized trial, and so it might disadvantage emicizumab in an NMA against Spinart, looking at factor VIII. Next slide. Potential other benefits and contextual considerations. For Valrox, there's the issue of developing antibodies to AAV5. There are other therapies that might be given with AAV5, including potentially other gene therapies for hemophilia, but also people have developed experimental cancer and infectious disease vaccines using AAV5. Even if there's only a limited duration of benefit, Valrox could allow a period of time where somebody is cured, essentially. So maybe you only have non-hemophilic range levels for 2 or 3 years, but if you wanted to go hike in the Himalayas for 2 or 3 years, you could potentially do that after gene therapy. There's clearly a decreased burden and use of time of administering prophylaxis, at least for a few years after gene therapy like Valrox. Emicizumab, similarly, is much less burdensome in terms of administration, including for caregivers. And this can lead to better adherence. But I don't want to downplay just the burden side. When we looked at the number of administrations of factor VIII that normally occur, we are talking thousands of IV infusions for a typical patient. And people should think about that burden and the implications of that burden for patients and their quality of life. And then for both therapies, we talked about this in our 2018 report on patients with inhibitors as well. There are past iatrogenic harms from contaminated factors, factors that were contaminated with HIV, devastated the hemophilia community, and then hepatitis C less so, but did the same thing. And often when there's been iatrogenic harms, we might be willing to pay more for therapies for a group in the future. Next slide. In terms of public comments received, we heard that our B+ rating for emicizumab was unreasonably high, and I'll come back to that. We heard about the issue that we're not giving emicizumab benefit for not leading to inhibitor development. And certainly, if emicizumab decreases inhibitors, it will have important implications, the development of inhibitors, it will have important implications for its value and use. But we don't know that for sure yet. And there's a randomized trial underway, so there's clearly some equipoise about certainty about whether this really occurs. And then we also heard, if you look at the data on Valrox and bleeding rates, even at fairly low levels of factor, there wasn't that much bleeding. And there were some suggestions that maybe people bleed less at the same factor levels with Valrox. This was in a tiny number of patients, and we think it is much too soon to come to that conclusion. Next slide. So in summary, looking at Valrox versus factor VIII, you have marked improvement in many patients for a period of years. You develop antibodies to AAV5 that could potentially limit future better treatments. And maybe you have the potential for long-term harm, such as liver disease. Putting that all together, we felt that the evidence was promising but inconclusive for Valrox. Next slide. For emicizumab versus factor VIII, we continue to believe that our B+ rating for emicizumab is correct for the lower doses of factor VIII used in Spinart. We agree that there were uncertainties versus the current doses of factor VIII that are being used, these higher doses that have some benefits, where we're uncertain of the exact magnitude of the additional benefit you achieved with these higher doses. Despite that, emicizumab clearly remains less burdensome than factor VIII. There's likely better adherence, so that outside of trials, you might expect better results with emicizumab. On the harm side, there were thrombotic complications seen with emicizumab in the inhibitor population, patients with inhibitor to factor VIII who received high doses of a certain bypassing agent. That has not been seen in this population to date, although there were always concerns with a relatively new therapy. Overall, we ended up moving our rating of B+ from the draft report to C++, comparable or better. That C++ says that we have uncertainty all the way up to it being substantially better than factor VIII. Next slide. And then for the comparison of the two, Valrox and emicizumab, we felt the evidence was insufficient. And I'll take any questions. Thank you.
So thank you, David. I want to now give an opportunity for our CPAC panel to ask questions. If you could, please use the raised hand function in the Zoom meeting, and I will call on you. Jason.
Thank you so much, David. That was a wonderful presentation, as always, really informative. I had a question about the nature of the real world evidence. So as we can see from your slide in the report, there was really a substantial, at least suggested a substantial treatment effect of Emicizumab when these patients were switched. And real world evidence is obviously very informative in a lot of different ways. It shows us how drugs are taken in real world life and sort of extends data from randomized trials. But of course, one of the difficulties with interpreting real world evidence is that there are new sources of bias that we would want to consider. And in particular, with this kind of story, I'd be concerned that, for example, these patients who were switched were for some reason not doing well on factor VIII in a way that doesn't represent the population as a whole. Or for example, had a lot of bleeds recently, in which case there would be a regression to the mean issue that potentially if you just did nothing, things might have gotten better. Now the effect that we're seeing is so large, maybe those sources of bias are unimportant, but I just love your thoughts.
I think those are both excellent points. Maggie, it looked like you wanted to respond to that.
Yeah, I can't find my hands up, sorry. I would have to say, thank you for that wonderful question. Patients make the decision to switch not based on the number of bleeds by far and away. The reason they're switching is because it's much less burdensome. The missing of doses because of poor adherence is what causes the major morbidity of the disease. Joint bleeds that lead to, pain, arthritis, needing surgery in their 30s or 40s. Here we have patients who are coming to us. We put out the options. We do not put them on it. They say, I want to be on that medicine. So this is patient choice. And it's not because they're having necessarily more bleeds. I have about 60 or 70 patients, and we've done some observational studies on them as they decide to switch. We are really, they're not doing it because of bleeds. Yes, there are a few. That was by far and away more the reason for the inhibitor patients who had very poor bleeding control because of poor medication or poor response to medications with the inhibitor. So I would really like to be sure that is stated clearly.
So I think we also have a comment from Steve Pipe on this issue.
Yes, I would totally agree with Maggie with her observations. In our clinic, we've had probably more than half of all of our severe patients have transitioned over to Emicizumab. Now, in the very early days after approval, we prioritized those patients who we know were being challenged by adherence to their regimens. Maybe they had continued target joint bleeding, target joint meaning they're bleeding into the same joint repeatedly. And we know that that is what sets up the significant pathology of hemophilia. So we did prioritize those patients early on to make sure that we got them in queue to get transitioned. But since that time, this has been a matter of preference for the patients. And I have yet to have a single patient who has asked to go back to regular factor VIII prophylaxis. Once they are on this and they see the transformative aspect to this care, they are unwilling to consider going back to factor VIII again.
So just to circle back to that, Jason, I do think you always have to worry about regression to the mean in these situations. We tried to pick that study in kids. Among other things, often the choice to switch children is because of the burden for the parents and the difficulties of infusing. And so that's one of the advantages of that one. We actually have the before-after study showing very similar numbers in Haven 3, but I wasn't presenting those to you very much because for various reasons, I don't trust them quite as much.
Thanks, Dave. Okay, we have time for two more questions from the panel from Rena Conti and Stephanie Nichols. First, let's go to Rena.
Thank you so much for the excellent presentation and discussion. My question is following up Jason's, and I have two, but they're related. My focus is on factor VIII therapy, and I'm particularly interested in how bleeds, pain, other types of burden, and other types of clinical sequela affect children relative to adults. And as a follow-up to that, I'm interested in understanding whether the higher dose of factor VIII is commonly used in children and whether it is universally covered by insurance in the US. Thank you.
I obviously should defer that to either Steve or Maggie.
Well, I could certainly start, and that would be to say that certainly over time, the lowest level of factor that we want anyone to have is about 3 to 5%. It used to be 1%. So this has evolved over time. But what is the impact of treating with factor VIII and questions about children? If you don't have an adequate level, you can't play sports. You can't have a reasonable quality of life. You have a lot of medical and avoid bleeds. There's a fear of even going out every day. It's a fear of a bleed. So it's a quality of life. It's an impact on all the activities of life, so that then you go through life and continue to have these kinds of quality of life and impact on your decision making and where you live, where you work, how you get along.
Yes, Rena brings up a really important point that I think is really hard to quantify, and that's how parents thinking about their children and how the child grows up in an environment of always having to be concerned about the risk of a bleed, the timing of activities related to their prophylaxis dosing. Those processes, those thinking processes become ingrained during infancy, actually, through the toddler years. And then the child grows up in that, always having to be cautioned about the timing of different activities. The spontaneity of life is lost in the context of regular factor VIII prophylaxis. You're corrected in the first few hours right after your dose, but very quickly you're down at levels that are back in the hemophilic range. And on a every other day regimen, at least during the second day, that child still has a hemophilia outright. And in the last probably 12 hours before dosing, they're at ranges where routine traumatic injuries can lead to significant bleeding. The trough level that Maggie talked about, targeted to 1%, that was always a concession based on the limited pharmacokinetic profile of the factor VIIIs that we had available for decades, really. It wasn't a target based that we knew that that was going to be effective. It was a minimally effective dose to make prophylaxis relevant. The WFH new guidelines that came out this past year, they've accepted that 3 to 5% really should be the goal for many patients. And the German guidelines have just come out where they have targeted that range as well. But even there, that's still a concession, because even with the extended half-life molecules, a reasonable regimen of prophylaxis is probably going to get you to that 3 to 5%.
Thanks, Steve. We have one more comment on this, and I'll go to Mark Skinner. And Stephanie has graciously agreed to hold her question to after the presentation of economic modeling evidence. So Mark, go ahead.
So Steve and Maggie, Dr. Regni and Pipe have summed it up well. I was going to comment on the trough levels, that the trough levels, which we've historically treated to, were really dictated by what was possible. And so the recent experience is what's made it different. I think the important thing, as an individual who's been through 6 decades, not the 7 that we heard about from Don Goldman earlier, but who's been through 6 decades of living with hemophilia, it's, I was born with it, and I don't know normal. I haven't had the opportunity to experience something other than bleeding, the pain that comes with it, the disability, or the limitations in life. And it's only when you advance do you realize, oh, this is how I should feel. You know, I shouldn't be in chronic pain. You know, I should be able to run across the street, or I should be able to do other things. And so sort of, it's only 12 orthopedic surgeries later that I now, you know, have the ability to do things because I've had treatment advances that have allowed me to improve. So comparing the thought process is often very hard to ask a young child or a parent, put my child on prophylaxis and put them through that. You know, when you're young and your joints are healthy, you bounce back pretty quickly, but the damage occurs with every joint. And so I had my first orthopedic surgery in my 40s, and I had 2 in the last year, you know, really correcting all of that early damage that wasn't being treated properly. So it sort of makes us crazy when we're told that we need to go through step therapy or we need to bleed before we can advance in our dose. That really is counterproductive for the long-term economic value that the new treatments can deliver. Don't make me bleed before I get treatment. Let's figure out what's optimized. Steve has described that very nicely, and that really should be what should be considered the starting point.
Thanks very much, Mark, for that comment. So now we will move to the presentation of evidence in economic modeling, and I'll introduce Suri Walton to you.
Hi, so I'm Suri Walton. I'm an economist and a professor in the Department of Pharmacy Systems, Outcomes, and Research here at UIC, and I led the economic modeling effort with a lot of help. Next slide. I received assistance from Danny Kwok, who's a PhD student in our department. We received money from ICER, and we have no other conflicts to disclose related to this topic. Next slide. So there were 2 primary specific objectives here. The first one was to estimate the lifetime cost effectiveness of Valrox relative to prophylaxis with factor VIII in adult patients with severe hemophilia A and without inhibitors. And related but separately, objective 2 was to estimate the lifetime cost effectiveness of Emicizumab relative to prophylaxis with factor VIII in patients with hemophilia A suitable for factor VIII prophylaxis and without inhibitors. Next slide. Next slide. So in the first model, model 1, this is comparing Valrox to factor VIII. It's in the United States. It's a Markov model. This fell into the ultra rare and into the single short-term transformative therapy frameworks in ICER. In the ultra rare framework, it's possible to have a dual base case of a healthcare and societal societal perspective. But in this case, they gave very similar results. So we just used the base case of the health sector perspective. This is a lifetime time horizon. We discounted costs and outcomes at 3%. The model runs on cycle lengths of 6 months. And we focused on quality, cost per quality adjusted life year. Because of the mortality assumptions, life years are the same across the treatments in our model, and the EV/LGY is the same also. So I'll just mention that now. And we also look at treated bleeds. Next slide. In model 2, it's also the United States, also a Markov model. This falls into the standard ICER framework. We use a health care sector perspective. It's a lifetime time horizon. We discount 3% again. We also use 6-month cycles. And again, we focus on cost per quality adjusted life year. Next slide. So this is a model schematic for model 2. Model 1 is very similar, just starts with a higher PS score. In the model 2, you start with no arthropathy, but you advance to arthropathy based on bleeds. And then there's Peterson scores in the model. And that's the framework to kind of tie bleeds into long-term development of joint issues and the need for surgery. So in the model, once you reach a Peterson score of 28, you have a surgery take place in the model, and then you return to a PS score of 1. And going on in all the cycles, there's 6-month cycles, there are bleeds being experienced, and that drives the costs and the utilities going on in the model. And there's also mortality in the model that is not different across treatment, but it's happening. So, and we run it for a lifetime. Next slide. So here are the assumptions. So first of all, the bleed rates for Valrox were based on projected factor levels that we had, and then using literature-based estimates of bleed rates across factor levels. So we kind of project the factor levels across time, and then based on the average factor levels across time, project bleed rates. When patients in the Valrox model reach factor levels below 5%, we in the model have 5% of them switch to Emicizumab. And when they reach a factor level below 1%, they all switch to Emicizumab. And we have them switch to Emicizumab in the model because we find that Emicizumab has the same efficacy and lower costs in model 2, as we'll see. But so just from an efficiency standpoint, that's why we made that choice. The bleed rates for Emicizumab are taken from the VIII trial. And the bleed rates for factor 8 in both models are taken from a recent published study that has average bleed rates consistent with these higher, more modern doses of factor 8 in US hemophilia treatment centers. We do view this as an evidence-based lower bound for bleeds associated with factor 8. Next slide. So often we just have treated bleed projections, and then we use the proportion of all the other bleeds in Emicizumab in the VIII trial to get the other kinds of bleeds from treated bleeds. So including all bleeds, treated target joint bleeds, treated non-target joint bleeds. These are all in the same proportion as in Emicizumab in the VIII. So that's an assumption. We also take, for all bleeds, we take an average of the number of joint bleeds to all bleeds in the VIII and in a more recent Potter trial to get an estimate of all joint bleeds relative to all bleeds. So these are treated and non-treated, because all joint bleeds are what are related statistically to the Peterson scores and what drive the transitions in the Peterson score model. The factor 8 costs are based on 2 representative treatments, Advate for standard half-life and Eloctate for extended half-life. And these are using doses and proportions of patients on those classes of drugs consistent with patients treated in US hemophilia treatment centers. And this is based on data that we got from ATHN. So we are using these representative treatments to do the costing. Next slide. In terms of bleeds, the utilities that we have, which are literature-based, the bleed are applied for 2 full days, and then an average of the no bleed and bleed values for the remainder of a week. And the cost of treated bleeds are the same for all comparators. They're literature-based. We use patient weights and mortality rates based on US male population averages, and there are no mortality effects associated or differential mortality effects associated with the treatments. Next slide. And just in terms of how these models run, in model 1, patients start with a Peterson score of 13. They're viewed as being 18 years old, and that's kind of the average Peterson score for an 18-year-old in the literature. And then we run the model from there. And in model 2, they start at an age of 1 with a Peterson score of 0. In terms of the transition rates, there's a 1-point increase for every 36.52 bleeds for patients under 25, and then for every 6.52 joint bleeds, patients over the age of 25, and this is based on recent relationships between joint bleeds and Peterson scores in the Potter trial. And again, at a Peterson score of 28, patients have surgery and then return to a Peterson score of 1. Next slide. So here are the bleed rates that are in the model. You can see that factor 8 and Emicizumab have the same bleed rates, and this came from the Moloch trial and the VIII. The Valrox bleed rates start very low and then get higher and higher and higher, and then they eventually become the Emicizumab bleed rates in the model. And this is based on that projection of factor decline associated bleed rates. Next slide. These are the health state utilities that we used in the model. These are EQ5D utility scores from surveys of patients and caregivers. There's also a utility of surgery that we used that is a time trade-off from all surgical patients, and we use a mix of like a month of the pre-surgery utility and then the Peterson score utilities to get that utility for that 1 cycle. Next slide. These are the per cycle disutilities of bleeds. They're They're based on the literature. There are also EQ5-based utilities based on surveys of patients and caregivers. There is a minus 0.16 disutility for a treated non-target joint bleed and a minus 0.28 disutility for treated joint bleed. I mean, treated bleed and treated joint bleed. Sorry. Next slide. These are the drug regimens that we use. And for the Advate and Eloctate, we have around 71% taking Advate and around 29% taking Eloctate. Those doses are per kilogram and they come from ATHN. And we use you can see what we use for Emicizumab. And of course, Valrox is a one-time dose. And we recognize that dosing in practice can vary widely from this. This is our representative dose. Next slide. Here are the treatment costs. We're using a placeholder price of $2.5 million for Valrox. You can see for Emicizumab, and these are for patients with a weight of 81.4 kilograms, which is the average for an 18-year-old and kind of a representative weight in the model. You can see the annual cost for Emicizumab is roughly $570. When you take the mixed average of the Advate and Eloctate, it's $633,000 per year, and the cost per bleed is $5,275. Next slide. Here are non-drug costs per bleed that we got from the literature. They vary across age, and there's also, we have an estimate of societal costs related to lost productivity and caregiver time. That's also literature-based. That's roughly $1,000 per bleed. Next slide. There are some other minor cost differences between having no arthropathy and arthropathy, and then there's a cost of surgery, and these are all literature-based. Next slide. Next slide. So here are the base case results for Model 1. You can see that factor VIII has far higher drug costs and higher total costs. It has, many thousand more infusions associated with it, more joint bleeds, more treated target joint bleeds. The life years are the same, and there are a slightly higher number of quality adjusted life years projected for Valrox. Next slide. So if you take the incremental results here, Valrox is much less costly and has a very slight increase in qualities, and so we call this a dominant treatment. Next slide. These are the results for Model 2. Here, Emicizumab has lower costs, much lower number of infusions, the same numbers of bleeds, and the same number of life years, and the same number of qualities. So that's what comes from the model here. Next slide. So Emicizumab is associated with lower costs and the same qualities, and so we're calling this a cost-saving treatment. Next slide. This shows the one-way sensitivity analyses in Model 1. You can see that drug costs and drug dosing matter a lot in the incremental costs. And down below, the probably not surprisingly, the number of bleeds matter a lot in terms of the incremental qualities. Next slide. And very similar results here in Model 2. Costs and doses of drugs matter a lot in the costs, and bleed rates matter a lot in the qualities. Next slide. If you run a full set of probabilistic sensitivity analyses, varying a lot of the inputs using distributions, Valrox is cost-effective roughly 94% of the time, and it doesn't vary much over the willingness to pay thresholds because the qualities are so similar. Next slide. A lower percent in all the sensitivity analyses we find Emicizumab cost-effective, but it still is roughly 60 to 70% of the cases. Next slide. So we ran a number of scenario analyses. So we tried using higher bleed durations. We used higher bleed rates. We used an older starting age in Model 1. We had surgery returning to a Pearson score of 13 rather than to 1. And we used societal perspectives in both of the models, and none of those had big results at all. Very, very, very similar results. We also ran a set of the SST scenarios for model 1. We had a conservative and an optimistic duration scenario in terms of projecting the factor levels across time. There was a proposed payment scenario where there'd be refunds for certain levels of factor, if they didn't get a high enough impact. And all those, Valrox remained a dominant treatment. Next slide. So we also ran a couple of limited savings that I thought I'd show the results of. In the first one, we cut the savings of the treatment of Valrox in half. And we also did a scenario where we capped the possible per year savings at 150,000. And certainly if you cap the savings at 150,000 per year, you get a big difference. There's a higher incremental cost. There's still some higher qualities, but you get a very, very expensive drug in that case. It's because we've capped the savings. If it's half the savings, it's still a dominant treatment. Next slide. So we also ran a couple of scenarios that took the NMA results. We used the doses of factor VIII from the Spinnert trial, and we used the relative rates of bleeds from that NMA to project the bleeds of factor VIII relative to Emicizumab, and then we threw those in the model. And if you do that, then Valrox has a higher incremental cost. It has a little bit higher incremental gain in qualities, but it's a very expensive drug per quality in that scenario. So again, using the lower doses of factor VIII and the relative rates of bleeding from the NMA, this is what we get. Next slide. If you do the same thing in model 2, it also results in Emicizumab having a higher incremental cost and a higher number of incremental qualities. But if you do the incremental cost effectiveness ratio, it's a very high price per quality gained in that scenario. Next slide. So here are the limitations. Both models are based on limited data, particularly for Valrox. We just have kind of the phase 2 data to work with and very few patients. The models do not include adherence. And there, it'll matter a lot what happens if you're not adherent. Do you go to no treatment? Do you switch treatments? How long you're not adherent? But those can all have, potentially significant influence. The dosing of factor VIII was taken from U.S. hemophilia centers, while those for Emicizumab and Valrox are taken from clinical trials. So real world doses may be different. We did not incorporate inhibitor development. We received conflicting clinical opinion about which regimen would lead to more inhibitor development, and it has already been shown that Emicizumab is a dominant treatment for patients with inhibitors. But again, if there is inhibitor ramifications of Emicizumab, it's going to make it look even better. Next slide. So the relationship between joint bleeds and surgery we recognize is imperfect, and the model assumes that, for example, you have one joint requiring surgery at a time. So this may undercount surgeries. We tried doing some sensitivity and scenario analysis around this, and it's not a large impact, but we recognize that. The utility scores for bleeds came from patients with inhibitors, so they may be different in patients without inhibitors. We're using a placeholder price for Valrox, and we are using Advate and Loctate as representative treatments. So the results of this model, may not apply to other products with different dosing and different prices. And we recognize there's a lot of different regimens out there. Next slide. So in terms of comments, in our original model, we kind of used the NMA as our base case, and we received lots of comments that the dosing should be based not on one trial of factor VIII, but more representative of the real world. So we switched to using these ATHN-based doses. There are a lot of comments on dosing overall, that dosing can vary widely, that there are other forms of treatment, and we recognize that. And dosing is a key variable. Costs and dosing are key variables in the model. We received a comment that maybe we should have used a pharmacokinetic-based model around dosing. I think that'd be an interesting thing to do, is a little beyond the scope for us. I think that it should, in theory, mimic the average dose that we used if you keep those same products. But it may have some interesting implications about potential variance in the doses and variance that you might see in the model. And accounting for treatment burden of factor VIII in the model. So We did not have high quality inputs on sort of a disutility associated with infusions in hemophilia, but we acknowledge it's certainly possible. And this is why we report the number of infusions, and you can kind of do the math yourself there if you'd like to. Next slide. So we conclude that with representative doses and a data-driven upper bound in efficacy for factor VIII and using a placeholder price of $2.5 million for Valrox, Valrox is a dominant treatment in adult patients with hemophilia A without inhibitors. With representative doses and a data-driven upper bound in efficacy for factor VIII, Emicizumab was found to be a highly cost-saving treatment with equal efficacy to factor VIII. And we believe that the analyses show that the results depend very heavily on the high cost of factor VIII products. So factor VIII is currently a very high cost comparator to start with. And with that, I'll take questions.
Thank you, Suri. All right, we have our first question from Steve Kogut.
Myself off mute. All right, thanks, Dr. Walton, for excellent work again. Kudos to you and your team. For the Emicizumab model, it was, you used an incident case starting point where individuals were a year of age or older. In the first years of use of Emicizumab, I would imagine that many patients are going to be switched over or starting at older ages. And just wondering if you could comment a little bit on the scenario analyses and the cost effectiveness in Model 2 if we're not looking at such a long time horizon for accrual of qualities and costs, but what would the real world might look like in the next few years as older patients may use this product?
Well, I think that's a good point. And I think that the data on children is a little bit limited. We had to make some assumptions based on the Haven trials to get those numbers. Obviously, in our model, the efficacy ends up being the same for Emicizumab and factor VIII. So if you start them at a later age, you're going to get the same result that Emicizumab is a cost-saving treatment with the same efficacy. So that's what the model will tell you. I don't know how much more I can say other than that. Margaret?
Yeah, just one note. Clinically, if we are starting, and it is now becoming normal to start Emicizumab very early in life. So the only difference then would be the amount of bleeds that you have during those first few years. Differences between VIII and Emicizumab, we may not have as much data. If there's better adherence, there's probably fewer bleeds, but I don't know that number, but that's what would impact it.
Thanks. Steve, you want to chime in on this topic?
Yeah, there's another harder aspect on the modeling, and that is that the timing of when bleeds occur in life have different implications over the lifespan of the patient. So we know from multiple lines of evidence that early bleeds in life have devastating pathologies because it starts the joint on a trajectory towards arthropathy, whereas it's entirely conceivable that if bleeds in particular joints could be entirely prevented until an older age, the trajectory would be quite different. So early prevented bleeds, beginning in infancy onward, are going to be captured with long-lasting benefits for the patient. So I don't know if that was thought of in the model or considered, but I think the timing here is critically important.
Thanks, Steve. Our next question is from Megan Golden.
Thank you for that presentation. This is kind of a general methodological question, maybe because I'm new to this, but can you help me understand the rationale for using the scenario where you cap the savings?
Yeah, maybe Rick or Steve could speak to that. That's from the SST framework. The idea is that savings of $150,000 is a big number. And so when you're bringing in a new treatment and it's being compared to an already very expensive treatment, and the question is, how much cost savings do Do you want to allow that treatment to be associated with, or should it be allowed to give because it's being compared with something that's already very high cost? So that's the rationale for the scenario, and Steve and Rick can maybe speak to it more. But
well, just you're previewing part of our policy roundtable discussion because it's meant to stimulate some head scratching around what we mean by value in this kind of context and what a fair price would be on the background of existing treatment. So that we'll come right back to that.
Thanks. Next comment or question is from Claudia Gruss.
Thank you. And thank you, Dr. Walton, for that analysis. My question has to do with the mode of administration. When it comes to IV versus sub-Q dosing, were there other elements of costs that were taken into consideration besides the cost of the medication, since there are very different routes of administration and other costs associated with that? And that was just felt to be negligible.
Again, we use the costs that I showed in the table are the costs that we use, and that's per dose. And we report the number of infusions, but we don't use any extra costs with infusion or have any disutility with infusion. So we recognize that as what we're doing, but that's what we did in the model.
Just in case it isn't clear, these infusions are being done at home. So there's not a facility.
It's not like, there's not like a facility fee, but.
Mark, did you want to say something about that, it looked like?
Well, I was going to comment sort of to that point. So when individuals, particularly early in life, when they are on home infusion, it does often involve the use of a home care service or early support and assistance. The other element, which is a cost that is displaced, is children often early in life have a port placed, which has a significant medical cost and risk of infection, which for future replacement. So there are costs beyond just the infusion that would vary between a sub-Q and a IV route.
Thank you. And we have one final question in this section of the discussion from Rena Conti.
Thank you for this outstanding discussion and the work that you've done, Dr. Walton. I have a question about utilities. Can you tell us a little bit about their measurement and specifically utilities as they were measured for pediatric or adolescent populations relative to adult populations?
Well, we get the utilities from a recent publication that has them vary across age and across arthropathy. It says that they were based on EQ5D surveys of patients or caregivers. So I presume that for the pediatric patient population, these were more likely to be caregivers. But I don't know the exact proportions or relative ages that were queried. I had to rely on what was reported in that table.
Thank you.
All right, thank you. Okay, we just want to cycle back before we take a very short 5-minute break to a question from Stephanie Nichols related to the clinical evidence.
Thank you so much. And thank you for both of those great presentations. For me, I'm really curious to learn a little bit more about the types of injection site reactions that can be seen. It sounds like many patients don't switch back for injection site reaction reasons or otherwise, but I'm curious about the range and severity of those.
I'll give that over to either Steve or Maggie again.
I'd be happy to just start off and say that with time, the minimal swelling or redness seems to dissipate and go away. And that's for all ages across all total dosing. So it's minimal.
In the clinical trials, about 20% of the patients or so have reported these injection site reactions. They're all considered mild, and in almost every single case have not changed the patient or the family's perspective on continuing on the therapy.
Great, thank you.
Thank you. All right, thanks very much. So we're going to take a very short 5-minute break, come back precisely at 11:31. and then move on to manufacturer and public comments. Thanks very much.